So friends, hello everyone. Andrei Berezovsky, Haxpolora channel, Health for All channel. Today we are in Turkey at the Memorial Clinic and we're talking about breast cancer. There has been significant progress in breast cancer treatment over the past 5-10 years. We're talking about who is in the risk group, we're discussing the sequence and the importance of accurate diagnosis. We're talking with a professor, with a doctor. The Memorial Clinic. We're discussing what treatment, what methods are necessary today in the clinic to preserve the breast. For example, that's because if you choose an organ-preserving surgery, the range of applicable treatment equipment is significantly broader. We take, for example, a sectoral resection or a total mastectomy. There may be an addition. A lot of sessions of radiation therapy, hormone therapy might be added, and targeted therapy could also be included. That is the spectrum. Today, having the necessary tools, equipment, diagnostics, and genetic tests is a must-have for successful treatment. That's why let's watch this episode with the professor from Turkey, from the Memorial Clinic. Feel free to ask any questions in the comments. If you have any specific questions about treatment, feel free to ask in the comments, and we'll ask the clinic to respond. Traditionally, we talk about health. Traditionally, this is Andrei Berezovsky, Turkey. And today, we're talking about breast cancer. Let's go.
We can define the group at high risk for breast cancer as follows. We can define it those with a family history of breast cancer and ovarian cancer. Secondly, those who consume excessive alcohol. Third, about obesity or the group of patients with a high body mass index. The fourth group includes patients who are physically inactive, that is, those who do not move much. We can classify these as a high-risk group. It's also about hormonal balance. We can also define early onset of menstruation, very late menopause, and long-term hormone therapy as groups at high risk for breast cancer. Breast cancer cannot be completely prevented, but we can reduce this risk in some women. What can we do about this? First of all, I want to share a few pieces of information related to lifestyle. One of them, to be active. So, per week, exercising for a total of 3 hours a week. It reduces the risk of breast cancer by about 10 to 20%. That's why we should lead an active and lively lifestyle. Finding a suitable sport or exercise for ourselves will help achieve this. Secondly, it's about diet and nutrition. The research has shown that the Mediterranean type diet, that is including seafood in meals and consuming plenty of fruits and vegetables, foods such as olive oil, it reduces the risk of breast cancer. We can consume more of this. Thirdly, alcohol consumption doesn't have a social impact, but consuming more than 3 drinks a week increases the risk of breast cancer. We can fix this. There are also risk factors that we cannot change. These are things like genetic family history. In this case, there are some preventive procedures. For example, if a genetic disorder is found in tests conducted on groups with a high risk of breast cancer, it means that the risk of breast cancer increases by 50% to 70%. Things that can be done about this are, there are some risk-reducing medications that we can use. Secondly, there are risk-reducing surgeries. Maybe everyone is familiar with the story of Angelina Jolie. One of them had breast cancer, and the other had ovarian cancer in her mother and aunt. The genetic disorder was also passed on to Angelina Jolie. This genetic disorder has a risk of causing breast cancer of about 50–70%. Therefore, a risk-reducing surgery was performed, which involved the removal of both breasts to reduce the risk of breast cancer, again, in high-risk groups. Screening will make a significant contribution by allowing the disease to be detected in its early stages, even in the precancerous phase.
One of the most actually sought-after protocols in almost every case. In diagnosing and staging cancer, especially in ecology, it's essential to have a 5-point scale to understand the spread of the disease, the possibility of vertical treatment, and so on. That's why actually in Ukraine we have only 2.5 or sometimes even 1.5, depending on the availability of radiopharmaceuticals, SOSC, RIM, and Memorial. Here in front of you are the sub-networks in the city with gallium, which is extremely important for a prostate cancer. To be continued. That's why the price is 750 euros is just $70. You can highlight the cues over the course of 2 to 3 days. Just keep this in mind, friends.
It's actually a breast cancer diagnosis. It starts with a physical examination and medical history. So, first of all, if a woman notices a lump, for example, when did she first notice this lump? Is there any relation to her menstrual cycle? We need to question these and inquire about the risk factors in the family history. After that, a physical examination needs to be done, because the physical examination is an important part of the diagnosis. Is there any suspicious finding in the clinical examination? Is there any pulling at the nipple? Is there any swelling in the armpit? Is there any thickening in the breast? Is there any discharge from the nipple? We need to see these. For the next one, we rely more on imaging methods. Mammography, ultrasound, and MRN are the imaging methods we use. We make this decision based on the woman's age. Generally, we decide on mammography along with ultrasound for women over 35. If she is under 35, we primarily request an ultrasound. Based on this finding, we request other tests. MRI is more in the high-risk group. So, we recommend it for those with a high family history, in the group where the lifetime risk of breast cancer is above approximately 20%. Sometimes it helps us as a problem solver. In the next step, we prefer to perform a biopsy for God's sake. For the biopsy, we prefer a thick needle biopsy. While surgical biopsies were previously at the forefront, treatment methods have now changed. In some patients, we can start with medication treatment instead of surgery first. Therefore, we primarily prefer a thick needle biopsy after imaging.
Hello, my name is Zulfiya. I am 33 years old. 3 years ago, I was diagnosed with breast cancer. After taking a shower, I stepped out and found a lump in my right breast, located in the outer quadrant. I didn't have any questions about choosing a doctor since I work at the Memorial Clinic myself. I chose one of the most renowned professors, Professor Fatih Aydoğan. After I went to see Fatih Aydoğan, he conducted an examination. After that, he referred me for an ultrasound to be absolutely sure that I had cancer. The ultrasound technician didn't like the images, so she ordered a mammogram. After the mammogram, I was referred for a biopsy to confirm that I really had cancer and not a benign tumor. After the biopsy results came in, a couple of days later, the doctor confirmed that I indeed had early-stage breast cancer. Do I have metastases or not? He referred me for a PET CT scan. After the PET CT scan, we understood that, fortunately, there were no metastases. And since the surgery was planned first, he scheduled an MRI of the breast for me. After the diagnosis, just a month later, Professor Fatih and I planned my treatment.
I want to show a model for this. The breast-conserving surgery we call lumpectomy involves removing the lump in the breast, meaning this specific area, followed by radiation therapy in the remaining breast area. There are different types of mastectomy, but if we are going to use an implant, it involves making a pocket in the breast from here to empty it out and then placing the prosthesis. There are different types of mastectomy. In mastectomy, radiation therapy starts under the armpit. We have two surgical methods, breast-conserving surgery and mastectomy. In breast-conserving surgery, we take clean margins around the tumor. We perform radiation therapy in the remaining breast area. There are different types of mastectomy, but nowadays we often prefer skin-sparing mastectomy. We make an incision here. We empty the inside of the breast. After that, there is no prosthesis. This is also called skin-sparing mastectomy. What kind of treatment do we provide for each patient? For this, the patient's breast structure, body composition, genetic characteristics, expectations, and tumor localization. For example, if there are multiple tumors, one here, one there, if there are two tumors, it's not very possible to do breast-conserving surgery. That's why we prefer mastectomy. Again, in the same high-risk group, we prefer to empty the breast, meaning we opt for mastectomy. Of course, simultaneous breast reconstruction with a prosthesis is commonly used because while treating the disease, ensuring a good aesthetic appearance is important to us. That's why we do this together. We make decisions based on the patient. So we are in an era of personalized treatment. Just like we tailor clothes to each patient's body, we create a treatment plan based on that, and we evaluate this patient as an individual.
He told me he offered several options for surgery. It was a radical mastectomy, the removal of the breast, and also a segmental mastectomy, just the removal of the tumor. I decided that I didn't want to have my breast removed. So they performed a segmental mastectomy on my right breast. They only removed the tumor. After that, we had a consultation with the oncologist, and the oncologist prescribed me chemotherapy, 6 courses. I completed all 6 courses of chemotherapy, and alongside the chemotherapy, so I was also receiving targeted therapy, which is Herceptin. The course was once every 3 weeks, every 21 days. After 3 courses, follow-up examinations were conducted. Next, we continued my treatment, meaning the chemotherapy and targeted therapy. The targeted therapy lasted for a year, meaning I received a total of 13 courses. We finished the chemotherapy after the 6th course. After the chemotherapy, since I chose a segmental mastectomy, which means just the removal of the tumors, I also had to undergo radiation therapy. After 6 chemotherapy sessions, I underwent 30 sessions of radiation therapy. It lasted about 5-6 weeks. Also received targeted therapy. After it was finished, in radiation therapy and targeted therapy, the doctor called me in so that the oncologist could invite me to prescribe hormone therapy. I need to take hormone therapy for 10 years according to the new standards. But just 6 months ago, after 2 years, my oncologist and I decided to stop the hormone therapy since I plan to have a baby. After I give birth to the baby, my oncologist and I will continue the hormone therapy. The active phase lasted about a year. So, taking into account the targeted therapy, it was 6 months of chemotherapy, radiation for about a month to a month and a half, and then more targeted therapy. So that's a year, a little over a year. I continued working, so after the surgery, I was discharged the next day, and I immediately ran to see my doctors and started my procedure.
And assess their treatments accordingly. It would be more appropriate if I showed it from here. I can also pull things from here if you want, but it will do. Give me the Gravo. This is explaining breast-conserving surgery. We take this area and the remaining area is treated with radiation. This is about the types of mastectomy with implants. Now, let me talk about something of the treatment. Methods. In breast cancer, the treatments we perform, such as radiation and surgery, are considered local treatments. The aim here is to eliminate the disease, and the radiation therapy is to prevent it from recurring in that area. Systemic treatment is in the form of pills that we use, medications, chemotherapy, and targeted smart drugs. We create a special treatment plan for each patient. In some patients, we start with surgery first. After that, if necessary, we continue with chemotherapy, radiation, and pills. In some patients, we start with chemotherapy first. This is more common in patients with hormone-negative or both positive groups. If the tumor is larger than 2 centimeters, or if there is disease under the armpit, we start with chemotherapy first. We give smart drugs in both positive groups. After that, we evaluate the sole response to the treatment. We continue with surgery and light as medicine. So we create personalized planning. Hormone-positive patients start with surgery. Hormone-negative or both, if tumors, 2 centimeter and armpit disease, start medication. 6, if there is disease, we prefer to start with medication treatment first. Start like this. I'll begin with radiological methods. As for radiological methods, today we use 3D mammography, known as tomosynthesis. Contrast-enhanced mammography has now started to be used. Artificial intelligence has become a bit more integrated. So, the doctor is present during the mammography screenings in artificial intelligence. We benefit from it, and it helps us see tumors that we might have missed. In surgical treatment, we focus more on what we call oncoplastic surgery, which means planning surgeries that not only remove the tumor in the breast, but also improve the cosmetic outcome. For example, we will perform surgery on a woman with a large breast volume. There's a condition we call macromastia. We are both removing the tumor and reducing the breast size. We prefer a treatment method like this. In drug treatments, one of the recently emerging methods that has come to the forefront is immunotherapy for triple-negative cases. Other smart drugs have been used for a long time, but some new drugs have been added to them. Again, some treatments used in new generation hormone-positive tumors. New options have been added. We are using these more frequently. In radiotherapy, it is mostly hypofraction, meaning that while previously treatment was done in 6 weeks, now treatments are done in a longer period of time. Sometimes radiotherapy methods that we call intraproprietary may also be suitable for patients. So these methods have started to be used extensively in breast cancer treatment today.
Or are they familiar with this acceleration, one of the most modern versions, that she convinced him, the doctor, allows for stereotactic radiation? Replaces. In short, a whole complex of accelerators, including to Sibirnaya Obgomonaya and also regarding the German accelerator and tubing. My memorial.
We use genetic testing for breast cancer for 2 reasons. One reason is that there are patient groups with a high risk of breast cancer. In those with a family history of breast cancer, ovarian cancer, pancreatic cancer, and male breast cancer. We check whether there is a genetic disorder in this group or not, because if there is a genetic disorder, it can also be passed on to family members, and we can implement risk-reducing treatments before breast cancer develops. The second genetic test is for breast cancer. Do women who are diagnosed need chemotherapy or not? We make a decision for this. This is actually called genomic testing. Oncotype, MammaPrim, or there are tests like EndoPredict. These help us determine the recurrence risk of breast cancer. If the risk is in the low group, we say that this patient can do without chemotherapy because the risk is low, so they may not need it. But in the high group, this patient, they will receive hormone therapy, endocrine treatment, but we also add chemotherapy to that. He said that these tests will make a positive contribution to the course of the disease and that he should do them accordingly. We use it to make decisions. Breast cancer can now be treated much better, as you mentioned, and the 5-year survival rate is over 90%. And patients can live for a very long time. Therefore, quality of life has become important now. For this reason, in the past we used to remove more lymph nodes from patients, but now we take fewer lymph nodes. So there are some findings related to this arm, such as lymphedema, which refers to restricted movement of the arm. We can achieve this or by taking fewer lymph nodes, or sometimes by following a path where it's not necessary. In the past, patients who had lymph nodes removed faced a 30–40% risk of lymphedema. Right now, the sampling method is more focused on that. During that period, we continued to remove lymph nodes even when there was disease present. But now, if there is only a small amount of disease, meaning if there is 1 or 2 lymph nodes affected, we can avoid removing them since the patients will receive radiation therapy. In fact, this year, at the San Antonio Breast Conference in America, a new study was presented. This study showed the following. In a certain group of patients, detecting tumors in the early stage now offers the option of not intervening at all, which used to be a fear. In this Excuse me, we prefer to offer the option of not intervening with the lymph nodes under the armpit to suitable patients. We prefer to offer this to the patient group. This prevents issues like restricted movement and loss of function related to the arm. Breast cancer can now be treated better and the disease is long-lasting. For us, the definition of being treated and health is actually the well-being of patients, not only physically but also mentally and socially. For this, we need to ensure this for women who have gone through this disease. Young breast cancer patients are very common both in our country and in neighboring countries. We also need to support their family and social lives. Nowadays, we can allow pregnancy after the disease has been treated. We have very young patients. These patients are disease-free for about 2 years after diagnosis. After a period has passed, we say that if there are no signs of the disease and if you are considering pregnancy, you can take a break. After that, you can continue with the treatment. This also needs to be ensured. We actually say this motto about our disease. We say, don't let cancer postpone your dreams. So a woman having breast cancer is not the end of the world. It's a treatable disease. After this disease, they have various dreams, they have expectations. We especially tell them to keep going with these.
Also after the chemotherapy. During the first courses of chemotherapy, since my body was still strong, I continued to work. I worked remotely, but I had the right to take a break. Of course, I could take a leave for literally 6 months according to the laws of Turkey, but I decided that I wanted to distract myself with something. It was very important for me not to be completely consumed by this illness, to distract myself with something else. And I decided that I wanted to keep working. I took leave specifically during the time I was receiving chemotherapy, and while there were side effects, it lasted for 10 days. Sometimes, during the last courses, it was 13 days. They were a bit hard to handle, and the rest of the time I kept working. The radiation therapy was really very easy. I would go to the clinic, spend literally half an hour on radiation, and then I would go to work. And the hormonal therapy, well, it's a pill-based treatment, so it didn't affect the continuation of my work at all.
We have a large team under the same roof, from medical oncology to radiation oncology, from plastic surgery to nuclear medicine, from breast radiology to pathology, genetics, obstetrics, and diet nutrition. Our entire team works together. In addition to the main team, our other colleagues, apart from the doctors, also provide support to our patients. For example, we provide support to patients regarding diet and nutrition. We have a breast health nurse. How will the exercises related to this arm be done? How will resilience care be provided, and how will they continue with their normal lives? They provide information and counseling on this topic because the physical aspect of the patients is important. Mental and social well-being is also very important for us. Exercises related to the arm are especially important. We explain these to prevent lymphedema from developing in the arm, and we do our best to be a guiding force in their future life. Okay, that's a very good question. So, the diagnosis of breast cancer, actually it can be diagnosed through self-examination. There are many studies related to this. Research conducted in Russia and China has shown that self-breast examination does not contribute significantly to the course of breast cancer. But actually, there are differences among countries and individuals. For example, a woman in China, she has a low body mass index and a fit physique. Even if there is a small difference, she will feel it herself. There's no need for her to have an examination once a month. While we can't adapt this for ourselves, I can say that self-breast examination is important for awareness. We prefer that women perform a breast examination once a month, especially after their menstrual period, for breast cancer awareness. Actually, the most important tool for the early diagnosis of breast cancer is mammography. Mammography has been shown to significantly reduce deaths related to breast cancer in many countries. Of course, the frequency of mammography screening can vary. For example, some women have it annually, while others have it every 2 years. In some countries it starts at age 40, while in others it starts at age 50, as I mentioned. This actually varies from person to person and from country to country, but at our center we create personalized plans. So we provide a form to evaluate a woman's risk factors for breast cancer. We assess the risk here and then we follow a path accordingly. For some women we prefer annual screenings, for others every 2 years, and for some women we add an MRI to the screening. But to summarize, breast cancer, I can say that the most significant factor in determining this is mammography screening.